Oh, I love it. Thank you so much. This is great. It sort of stinks that it takes a pandemic to be connected to all of you guys, but I really do appreciate that invitation. Such a nice introduction. The reason I really enjoy talking with you is that I get to learn from you more than I could ever teach. So, for example, all those questions I had for this whole group, Dr. Keeve answered in terms of the impact of the pandemic on their practice over there in Spokane. And I would love to hear about that from all of you guys. Time is tight, and my prediction is that if your life is anything like mine, you're probably sick of going through the valley of Zoom. So I want to keep this as interactive as I can. I do have some introductory remarks regarding some of the questions that Jens has asked, but hopefully we have time for some interactivity. And please do keep me on time because I'm not watching the clock. So you need to, otherwise I'll go all night. I will. So you call me off when we're getting close to the end of the time, if that's okay. And thanks for these interactive questions as well. You know what I'd like to do is share screen here for a moment. This is a little unusual. Typically for a nice lecture invitation like this, I would have a full set of slides, and like that nice slideshow you just saw, I'm just too damn busy, so I apologize. But this is what I thought would be most helpful for you that I just cobbled together during those introductory remarks. Let's talk about COVID-19. The epidemiology, where are we? I think you guys understand the situation. It seems nationally that every day is worse than the day before. This isn't necessarily going to be true for much longer. If you look at the list of the top 20 deadliest days in American history, 18 have been within the last month. It's like that. And yet, I think the Galveston hurricane was a bad day. There may have been one other bad day, the Battle of Antietam or something. But otherwise, when you get to the level of 3,000 or 4,000 Americans dying of one cause per day, this is what we're talking about. And yet the curve, we hope, really can start to turn. Let's look at Washington State. This resource is one that I suspect all of you know. This is the Institute for Health Metrics Evaluation, IHME. They do this for each state, but they happen to be based here in Washington. So we really do trust the level of accuracy and the predictions and the models that they build. So what they're looking at, I just showed you deaths. There's a lot more to COVID than deaths. It's about economics. It's about the fraying of our social fabric. But if you just talk about the ultimate metric, legs up, legs down, this is it. And they are predicting that we will end up with over 6,000 dead by the beginning of May. They are very humble about this. If we as a society can do the right thing by immunizing like crazy, and being careful with our personal protection, which we'll talk about, this number, we can bend it down. And if we screw up, we can certainly make it worse. But that's our local experience. And to me, I didn't show you the map because I ran out of time to build it. But for me, what's so humbling about this is the fact that this is not a Western Washington problem. When this first came out, we knew this was going to be urban, the Pacific coast. Absolutely wrong. This is a statewide disaster. And those of you who are on the eastern side, those of you in the center of the state, you're dealing with it every single bit as much as we are. In fact, in some cases, much more heavily, because the resources for human resources, the pool of labor to draw upon may be reduced. And so, thanks to all of you for providing the care that you do in spite of these incredibly difficult odds. One of the things that Jens wanted to talk about over here is these New Mutants. Apparently the New Mutants is a movie. My teenage son says it's not a great movie. I don't know if that's true. But when we talk about New Mutants, we're talking about mutations coming across the global pool of viruses over time. Let me just be very clear. Cast your mind back to medical school. Yes, mutations are expected. Remember, the coronavirus, whether it's human coronas that we've all had in the past or these animal coronas that we're now dealing with, they are made of RNA. Their blueprint is RNA, not DNA. That's key because it means that, like influenza, they're very error prone. We love being made of DNA because we can have a carbon copy every single cell, except when we catch cancer or make a sperm or an egg. Every other cell is like the others. For COVID, it's not that way. They turn over very quickly. They're very error prone, which to us in our arrogant eukaryotic ways sounds terrible. If you're a virus, you love errors. Errors are your best friend because even if 99% of them lead to death of the virus and it fails, one time in 100, one time in 1,000, one time in a billion, you're going to have a mutation that actually confers a selective advantage. Charles Darwin knew nothing about viruses, but he knew evolution and he knew what natural selection was. So the one that you have heard the most about is what you see here. I like this graphic from the New York Times, looking at mutations in the so-called B117 or UK variant, UK mutant. I'm actually more worried about certain mutations coming from South Africa we'll talk about. But basically what we're talking about is that in a certain region of the RNA that encodes for the spike, remember the spike is what gives the surface radiation, the corona look to the virus. Those spikes at their very tip, they will bind to the ACE2 receptor in the human lung and respiratory tree. That's how they hold on to us. That's how they infect us. And in the case of this B117, these mutations lead to amino acid substitutions. This is what the spikes look like up close. This is the amino acid sequence. And these are the mutations. So they're very few mutations, but what they do is actually confer a more fit tip or binding domain on the surface of the spike. What that means is that the virus isn't smaller, it's not bigger, it's not faster, it's not more durable, it's just stickier. It holds on to the target within the human body more avidly. And what that means, of course, is that the effect to us as clinicians is that the load, the amount that would infect, the infectious dose is reduced by 50%. These are 50% more catchy, not 5,000% more, just 50% more. Doesn't sound like that much, but in an logarithmic pandemic situation, these little changes can have huge implications if we fail to protect ourselves. So the biggest questions that come with respect to these mutants, and again, what I'm showing you here is B117 UK. There are a couple of others in South Africa, not yet detected here in Washington State, although they may well be. It's possible. They are more catchy. And the question is whether they are also more or less virulent. We'll come back to that in a moment. The quick answer is we're not quite sure that that's true. The diagnosis has been an issue because the tests that we do, molecular-based tests, the dreaded, what does one of my patients call it? The devil's fire stick you stick up your nose. That's a PCR test looking for the RNA. And that RNA, if the RNA backbone changes of the virus, the negative predictive value of the test may be implicated. And indeed, beginning of this month, this message was sent out by FDA warning laboratories, not clinicians, but labs, that if they use one of a small number of proprietary lab testing platforms, they may have a harder time detecting these new mutants. The truth is, this is not felt to be the case for most of the testing that's done in America. This is a small number of vendors that have this issue. And frankly, every lab in the country is now scrambling to make sure that their primers set, the accuracy and reliability of their tests remains up to date. Here in Western Washington and across the entire state, you can at the moment depend and rely on the tests that you get. So in spite of letters you see like this, we still think that standard PCR testing is good. And the same is true for antigen testing. If you're actually doing antigen testing, you happen to work for a university that's doing frequent antigen testing of football athletes and such, those tests should also be as accurate as they were before. The mutation has not yet eroded their issues. Again, I think the bigger issue that comes up, we'll come to this in a moment, is about masking. What have you heard about masking and prevention? Is it time to double mask, to upgrade your mask? We've had the mantra this whole time, right? Cover your face, give yourself 6 feet of personal space. Don't go out if you're sick. And if you do see other people, do it outdoors. That's what we tell the general public. What we're telling healthcare providers like all of you is get your damn shot. So the immunization piece as soon as possible. So appreciate that question we had a few moments ago. It looks like most respondents here tonight have been fully immunized. Great news. I'm one of those. If you have not yet, it's good news. You should soon have access to that immunization. Everyone who's a patient-facing clinician is under Governor Inslee's guidance, which is in keeping with CDC. You are authorized to get it. And there should be an opportunity in the very near future for you to be immunized. If you have questions about safety, effectiveness of the immunization, I'm happy to take those either in a group or we could do it as a private chat too. There may be medical issues that you have questions about. I'm happy to do so. What's so stunning to us on the immunization side is how incredibly effective and benign these shots are. It's very strange. For me, I don't know about you, I got my first shot. I happen to be Pfizer recipient. And then when I got my second shot, unlike the first time when I had a little bit of a sore shoulder, I actually had a cytokine flow. I was too sick to come into work. At UW, like where you work, you can't work if you feel sick. I felt sick. I had fever, felt feverish, chilled, muscle aches, my ribs, my sternum, that hurt, everything. Next day I was fine. That's a small price to pay for what we know is a substantial improvement in the protectivity against COVID, wild type, old school COVID. And yes, we are confident and optimistic about these UK variants and also potentially the variants coming from South Africa. When you get a vaccine, there is a polyclonal explosion of B cells that will attack different portions of that molecule of interest, the antigen. It's not just one clone, it's many clones, meaning that there is some healthy, beneficial lack of focus, more broad protection than you would get if it was just one clone. So that's good. And we do think that based on serologic studies, that most recipients who have a good immune response to their shot, they should be very well protected against the so-called UK variant. It's here in Washington state. We have detected it on a small number of cases here in Western Washington, and no doubt that will come to be true in Eastern Washington. I've been working today, haven't checked the news. It's probably already been described. If not, you should assume that the UK variant is in your community. That's key because you can practice with confidence if you yourself are immunized, but you need to continue to do the basic protectivity that we would always do. Not necessarily because we think the UK variant is more likely to break through the vaccine, but because for any viral type, including wild type virus, you're not 100% covered. You're probably more than 95% covered. Someone's going to be in that small fraction that might not be covered due to random chance, due to immunosenescence. As we get older, we get less of an immune response. So we should all assume that we are at risk of having exposure to this infection and continue to practice masked, but I think with greater confidence, a little bit more spring in our step, and a sense that we are probably protected. Thus, the slide that I show you here regarding double masking, the issue, as we talked about, is that you have a smaller infectious dose of these new mutants. It takes less virus to infect you, so unless you are quite meticulous and perfect with your technique, there's a greater threat, a greater likelihood that people who especially have not been immunized, they can now catch this infection. Cloth masks work. That's what I wear. This is what I wear to my car. I've got one of these little cloth masks here. Happy to do it, and it's opaque. When I hold it up to the light, I cannot see through it, not just because it's black, but because I've got enough layers of weave. So even if I were not immunized, actually I would be good in a single layer of mask. Having said so, for people who are less choosy, less willing to spend money on a good mask, yeah, sticking a second mask on is completely fine. And if your patients, family members, friends, and well-wishers ask you about that, should they wear one mask or two, if people are asking the question, they've got a certain sphincter tone on them, feed that sphincter tone, put them in a second mask, it's fine. The trick is whatever they wear, they cannot fiddle with it, they cannot fuss with it, and if it fogs their lenses, then it's the wrong answer because that's not sustainable. That will cause hand to face, including conjunctiva. That's a risk. So you'll hear a lot more about double masking. I think you're going to see a lot more of it in the community. I think it's fine. It does not get us out of where we are in terms of providing exponentially more protection for the general public, and it doesn't get us out of our issue getting each other and ourselves and our families immunized as soon as we can. So the basics of prevention stay the same. Yeah, question, please.
Interrupt you quickly. Great questions from the audience. Superb insights. I could listen to you all evening on, but we'll have to obviously move on. Dr. Galina asks, how long does immunity from the immunizations last? So we'll shoot there. And number two, Dr. Hagen asks, can you carry or transmit the virus if you're vaccinated? For instance,
Yeah, great question. So neither one has an answer. We don't know, but I can tell you what I think. We don't know how long the immunization durability lasts because we only got these things approved a month ago. We are literally too early. I'm optimistic based on these screaming high titers that we will probably have lifelong or at least more than a year of immunity. Could we go into a seasonal influenza situation where you got to get your annual COVID shot? Yeah, it's possible. No one yet knows. Number two, can you then shed the virus even if you've received the vaccine? Not clear, probably not. And if you do, it's probably very little. That's based on one subset of one of the vaccines called Moderna, in which they did not find that vaccine, they did not find that recipients were able to shed the virus. The reason I'm hedging on this is that it's a huge issue for us in our healthcare setting here. It's a very hot topic in infection prevention, employee health. We will get the answer to your good question, I hope, in the next month. That's Pfizer and Moderna really want to answer that question, because when the answer is no, then people will feel even more excited about getting their shot. Meantime, even if you are a vaccine recipient, healthy specimen, good immune system, you still need to mask up because we have to assume that you might be a threat in terms of shedding to others. The only other thing I wanted to say, because I do get this question sometimes, is on treatment. And if you are to get sick, how would we treat you? If you want to learn more about this, we have a nice website, which is here, put together by my colleagues here at UW, called COVID-19 Treatment. It's a series of free slide decks on this topic. The quick answer is there is no treatment ever studied proven to save lives, ever. hydroxychloroquine, ivermectin, monoclonal antibodies. Nothing's ever been shown to keep people alive. There are some treatments that seem to be associated with a lower risk of severe disease or hospitalization. And in particular, that's a combination or cocktail of antibodies made by a company called Regeneron. And when these are combined together, given to nursing home patients who've been exposed to the infection or who have early infection, they may be less likely to have to go to the hospital. So we're excited about that. It's still very early days with respect to those data. And one of those studies, actually called Blaze, was just released a couple of hours ago. I haven't looked over that yet. So we're hopeful that that might work. These are antibodies. They're infusions that take hours. They have to be done in a hospital using an IV. We won't get out of our pandemic by using these antibodies, is what I'm trying to say. Only the vaccine and good personal responsibility can do that.
Our board member, Alan Greenwald, asked, just on a big picture perspective, and then Galina had another question, Dr. Galina. He asked, this herd immunity concept was such a giant thing. Is 60% that critical epidemiologic threshold, and when we can kind of bend the curve? That's been an overused thing. And please fill out the final COVID question that we are just posting right now for all the audience members.
Yeah, I love that question too. I'm eager to see what folks think of that. So regarding herd immunity, great question. I'll stop my share. We don't need that anymore. Which we also call community immunity. The herd refers to rinderpest, which is the measles of cows in Africa. But yes, herd immunity, that's what everybody calls it. So modeling from IHME, from NIH, CDC, and WHO, they all end up at roughly that same number, that we will not bend the curve until we reach at least 70%, at least 2/3 of the vulnerable population should be immunized. What's so intriguing to me is that, of course, that number depends on the efficacy of the vaccine. Vaccine's 50% effective, you're gonna have to get higher than that. This vaccine is highly, highly protective, and therefore we might be able to get away with a smaller number. I don't think that that gets people off the hook with respect to personal responsibility in getting their vaccine. But I would say, because we have such a small supply of this incredibly precious resource, it does give me hope that we may be able to bend that curve sooner than we would have thought. I can tell you here in my hospital, we have a very big hospital, tens of thousands of people in our whole system. All of our healthcare workers have been offered the vaccine. Almost everyone has taken it. We have zero. I'm knocking on, there's not a real piece of wood in this whole damn room here.
I'd offer you my head.
Thank you, sir. I'll do the same. We have not yet had a failure. We've not yet had one healthcare worker break through, either with a community exposure or healthcare exposure, if they have received the vaccine. Remember, your maximum protection begins about 5 weeks after your second injection. So we're just now getting into that phase. But even before we reach maximum titers, very, very protective. And I love seeing these results.
Can you see the screen, Paul, with the poll results? I think I should not book an expensive cruise until after middle of 2022.
I think what you are likely to see, my friend, is that if you want to be a high roller cruising and such, you probably need to have proof of immunity. I think we're going to split into two societies in this transition period, where people can either wear their badge of honor, I've got my vaccine, then casinos, music venues, cruises. That probably could be a realistic thing. In fact, I think I just saw on the news a couple of days ago, there is one cruise line that's doing this for early adopters. It's an incentive. Having said so, when do we get back to normal? It all depends on these next few months. Can the new administration deliver on the promises they've made and exceed them? I think they've promised 100 million doses in 100 days. They need to do more than that. Remember, when we talk about doses, it takes 2 doses to get immune. So they really need to do more. And if we can actually revolutionize things, don't ask a hospital to immunize folks. Have it happen at the post office, at Starbucks. When the Amazon guy comes to your door, he gives you a shot. We need that kind of radical thinking to quickly get past this. And I'm really hopeful that we can do. Exactly when the time will be there, I don't know. In
the New York Times today, there was this incredibly encouraging article from Israel that showed, as you know, very, very positive results with a better than predicted immunity to at least the Pfizer product, which I received also. So 2 more questions, then we'll probably have to move on. Again, this is so fascinating. Thank you so much for jumping out of your meeting to our meeting and educating us. So quickly, Dr. Galina had a question I thought was cool. If a patient had COVID, when can you start get immunized formally?
Yeah, nobody really knows. The guidance says that you can be immunized anytime. You may choose, I think the word CDC uses is may choose, to delay by up to 90 days. The concept is that once you've had COVID, you are unlikely to catch a second case within 90 days. We have seen this. Actually, it does happen. My personal guidance to those people is give yourself a month off and let us catch up with everybody else who's still vulnerable. And then at the end of 30 days, get your shot. I have not come across someone who has a legit second infection within a month, and very rare within 3 months, but within 1 month, I just have not come across that. That allows us to take that one precious dose and get in the arm of somebody different. So that's what we say, but you can get it done anytime. There is not a rule.
We probably have to reschedule another meeting with you because the questions just keep flying in, but this is obviously so near and dear to all of our lives and livelihoods and the lives that we're asked to protect. So very quick fire, just quick question. So PCR tests, too sensitive, almost yes or no answer. Are they just too sensitive? Is the bar too high? The dilution protocol is too far-fetched?
Yeah, don't test again. No test to cure. They're hypersensitive. They pick up cases within about 48 hours after infection. First 48 hours, you can't trust them as much as you can. But once they're positive, that person may stay test positive for weeks or months. Don't test again. Just go by time. You can take that person, they're coming in, they want to get a hip or a knee. They happen to have a pre-procedural screen. Fine. Reschedule them for 20 days later. Even 10 days, to be perfectly honest, if they weren't going to get intubated, your colleagues in anesthesiology will thank you. If you make it 20 days, the chance of that person then spreading COVID out of their trachea during the case is zero. That's what we do here.
Final question from mine, then we have to come to a close. Sorry for all the questions that are coming in. You're just a great speaker and such a fund of knowledge. A politically charged question, so a light one to end with. How can we trust those COVID death numbers? Again, there are all sorts of paranoias. I come originally from Germany, and now there's a huge debate as to what games are you really playing? What's really a COVID death? The standards are very different. So maybe a word of wisdom on trusting numbers and how can we trust numbers? Where are the boundaries?
Yeah, great question. It's a great question. Early in the pandemic, it was clear that we were probably having real issues with case definition. Remember all those nursing home people who died, case fatality rates of 50%. Our case fatality rate is now down to less than 1% because we're able to test so aggressively. So it's a great question. My thought is that our testing in the US today is so sensitive that we are really able to pick up the great majority of these cases. And yet, if you look at the total number of human beings who have died in our country in calendar year 2020, and compare that with calendar year 2019, there are a difference of approximately, I think, 150,000 unexplained deaths, excess mortality. These are people who did not have a COVID test, but they died for any number of reasons, and you know how the coroner reports go. So the answer is, I think we can trust the numbers. They clearly are undercounting. We clearly have a greater burden of COVID-19 than we know because some people just don't get tested. And the numbers don't lie. Those actuarials are real. There are a lot more people dying out there than we have even tracked. We assumed they're COVID-19. The numbers you get officially from state departments, except for Florida, which is just a weird place apparently, but except for Florida, the other states will give good numbers and they're apparently, I think very reliable. I know we're out of time. It's totally up to you. I'm happy to go mute and then reply. There's a little chat function. I'm happy to chat back to folks. These look like great questions over here. If that's suitable to you.
I have one more question. For.
Oh, sorry, we lost your audio again. Sorry about that.
Neil is going to talk about ASCs. Is it safer for a patient? COVID and those other microbes we're forgetting about, those little things called staph and strep and whatever. Is it safer from an epidemiologic perspective to go into a small controlled environment like an ASC rather than a big hospital where there's some godforsaken bugs floating around? Just big picture.
Not COVID, but you're thinking about bacteria. I think it's all about the level of excellence and quality that's brought. There are so many excellent so-called day centers, surgical centers. As long as there's someone, in my experience, who is responsible for the quality control, looking at the data and implementing best practices, that can be fine. The State Department of Health, I think, is I was going to say biased against. I think they've been burned with some day centers. I'm not thinking of ortho, but just day surgery centers, because often that level of quality and staffing is not there. There's no reason that that should be true. We struggle with our staffing here at this hospital, and as you know, we're a big ass hospital. There's no reason why a smaller center should be any less safe. Indeed, theoretically, should be more safe if they're willing to invest in what it takes to do that, which is, I'm sorry to say, human beings who do nothing but that. It's a dedicated discipline. I think that quality control, infection prevention is the price of doing business in orthopedics. It's not something that can be done on the sly, on the side. If so, you'll get burned. That's my thought.
Absolutely outstanding. Please accept our collective thanks. If you are able to take some of those questions online in the chat function, fantastic.
I'll do a
Great
little
segue to our
access.
final speaker. So